welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Hi, everyone. Thank you for joining us for the March ACCP EMED PRN Journal Club. Today we have Annika Meyers, who is a PGY2 emergency medicine pharmacy resident at Memorial Medical Center, Las Cruces. And today she will be presenting a journal club on the effectiveness of intramuscular naloxone 1.6 milligrams, in addition to titrated intravenous naloxone 0.1 milligrams for opioid poisoning, which is a randomized controlled trial.
All right, so just a quick bit about naloxone, which hopefully all of you are a little familiar at least. It's a full mu-opioid receptor antagonist, so it displaces other opioids from the mu-opioid binding sites, which leads to reversal of opioid effects. And we do have a lot of dosage forms that naloxone comes in, so IV, intranasal or IN, intramuscular as well. And there is a lot of literature actually out there about the utility of different dosage forms of naloxone. So what I kind of wanted this slide and the next slide to highlight is that there is a lot of research out there, but also a lot of it focuses on intranasal versus intramuscular. For example, these all looked at intranasal versus intramuscular. And then they also had a couple double-blind, double-dummy randomized control trials in the last couple of years that looked at intranasal versus intramuscular naloxone for opioid overdose and found that the IM naloxone was actually typically more effective. And then there's also this study from 2022 that looked at the frequency of agitation after an IM naloxone dose. So they found just 3 cases, required chemical sedation. They found severe agitation in about 7% of those cases, so pretty low incidence rate. But what that means is that there's not a lot of literature on intramuscular versus intravenous use. So we have this literature that shows intramuscular can be more effective than intranasal, but we don't have that in intramuscular versus intravenous. But it's not always possible to use the best practice of IV titrating, slow boluses, and monitoring respirations closely, especially if you're in a really busy environment or not in a good healthcare setting where you can monitor those parameters. So the objective for this study was to assess the effectiveness of intramuscular naloxone in addition to these IV naloxone boluses in preventing respiratory depression recurrence in suspected opioid poisoning emergency department patients. So in terms of the study design, this was a prospective randomized trial. It was a single center in Brisbane, Australia emergency department, and they did blind the treatment team and data collector. They either administered an IM naloxone dose of 1.6 milligrams or an IM placebo saline dose with their initial 0.1 milligram IV dose. And then they had a standardized care pathway that they followed for monitoring the patient after they initiated the naloxone doses. So they would start an infusion if the patient needed any additional doses more than 2 hours after they got that first dose, or if they had 3 or more episodes of respiratory depression. And something about the study that I did want to point out is that patients who got pre-hospital naloxone, so like from EMS, from a bystander, were still eligible to be randomized into the trial if they fit these inclusion and exclusion criteria that I have on the right here. So inclusion criteria was just age 17 years or older. The treating provider ordered naloxone, and then they had suspected opioid poisoning, which they defined as less than 10 respirations per minute, or having an oxygen saturation of less than 93% on room air. And then they would exclude the patients if they did not have IV access or if they had significant delays in obtaining IV access, if they were intubated or mechanically ventilated, if they had any opioid poisoning following pain treatment, so not necessarily a drug overdose, and then if they were in custody of police at the time of their visit to the ED. In terms of statistical analysis, they used a two-tailed Fisher's test with a p-value of 0.05 for their statistical significance, as well as median and interquartile range. And then they calculated that they would need 102 total participants, so 51 per arm, for a 95% power to detect a 29% risk difference. And then they also increased their required number of participants by 24%. So they had 63 per arm for a total of 126 to account for the potential of any patients who were recruited into the study that did not actually turn out to have opioid poisoning. They just presented like it and were recruited into the study. So their study population was gathered from October 2021 through October 2023, and they randomized 136 patients. They did ultimately exclude 18 of those, 3 because they were mechanically ventilated, and then 15 that they later determined to be a non-opioid poisoning source of their emergency department visit, which left 118 patients for their per protocol analysis. So they had 69 in their IM naloxone treatment group and then 67 in their placebo group. In terms of demographics, there are a couple of things that I wanted to point out that are kind of unique to this patient population. So they did see that 9 patients in their treatment group, so about 13%, and 16 in the placebo group, about 24%, did get naloxone prior to arriving at the hospital. And this was sometimes given as an intramuscular dose, actually. So 2 of the treatment group patients and 11 of the placebo group patients did actually receive the study 1.6 milligram intramuscular dose prior to their arrival at hospital and being randomized into a group. They also noted that heroin was the most common poisoning agent. So they asked patients if they knew what they had overdosed on. About 35% of the treatment group and 46% of the placebo group said heroin. That was followed by multiple opioid agents and oxycodone in terms of prevalence. And then I also wanted to point out they did not collect any fentanyl poisoning, so no patients attributed their overdose to fentanyl. And then the majority of patients, about 64%, overdosed on a short-acting opioid, about a fourth or 26% overdosed on a long-acting opioid, and then the remaining patients either didn't know what they overdosed on or it was multiple things that they took. So in terms of their primary outcome, this was defined as the proportion of patients with respiratory depression recurrence. So I have the definition there for you, but essentially if they had respiratory depression in the 4-hour period after they got those initial doses. So I have the intention to treat group as well as the per protocol group. So for intention to treat, they found 31% less recurrence in their treatment group versus per protocol, they found 38% less recurrence in their treatment group. And they did also calculate a number needed to treat for the intention to treat group, which was 3.2. So for every 3.2, or essentially for every 4 patients treated with an IM naloxone group, they avoided 1 respiratory depression recurrence. And then they did also track some secondary outcomes as well. So they looked at time to respiratory depression recurrence, percentage of patients requiring naloxone infusion, total number of the bolus infusions that they needed after getting their initial dose, and then the percentage of patients who had a reversal after 10 minutes. And then they did also look at the withdrawal symptoms, which I thought was very interesting. The 2 that are bolded are the 2 that are statistically significant. So the percentage of patients requiring naloxone infusion was significantly less, 30% less in the treatment group, as well as the total number of naloxone bolus infusions were significantly decreased in the IM naloxone group. They required a median of 2 if they got an IM naloxone dose versus a median of 5 if they did not receive that dose. We did also note that their time to respiratory depression recurrence and the percentage of patients who had a reversal after 10 minutes was approximately the same. And they did also point out that they felt their incidence of withdrawal symptoms was similar in the 2 groups. It was not statistically significant, although it was numerically higher in the intramuscular naloxone group for 35 patients or 51% versus 28 patients in the placebo group, which is 42%. So going into discussion, in terms of strengths, I feel like this is primary and secondary outcomes that are actually applicable to the real world and real world concerns. I think one of the concerns I had when I first read this article was incidents of withdrawal and precipitating that situation. So I like that they looked at the agitation and withdrawal symptoms, for example. They also based their IM dose on their previous literature that had showed a good efficacy, but a fairly low incidence of severe agitation and withdrawal. So they did take that into consideration, as well as the fact that they offered all the study patients take-home naloxone at discharge. And then a couple limitations. So unfortunately, the study groups are a little imbalanced because of the randomization process. It's not perfect, but it is also something that they couldn't really control just due to the nature of their study design. And they did also have subjective causative opioid information because that was reported by the patient. I also wanted to point out that the study was done in Australia, so they do have different prevalences in terms of their opioid supply and drug supply versus here. For example, heroin was the most common in the study, but fentanyl was the most common in the United States typically versus heroin. And then they did have that caveat also of some patients in the placebo group receiving the IM naloxone prior to the hospital arrival, which may have skewed their results a little bit. In terms of conclusions, so they did conclude that adding the intramuscular dose reduced the respiratory depression recurrence rate, and they attributed this to kind of a slower, more sustained release of the naloxone with the IM administration versus IV or IN, which is typically like very quick acting and not sustained. They did point out that their withdrawal and severe agitation rates were numerically higher with the IM naloxone, but they didn't feel that this was clinically significant. Then again, they only had 118 patients included in their analysis, so it's hard to tell if this really is clinically significant from such a small sample study and a population that is not in the US. So they ultimately decided that intramuscular naloxone can be helpful in certain settings, especially pre-hospital settings, busy emergency settings where you can't monitor the patient and do those IV bolus titrations as much as you would like, but it may also not work for all cases. So for example, long-acting opioid preparations, it may be tougher to use IM naloxone in these patients. So going forward, unfortunately, I don't feel like this has a super high clinical applicability to us in the United States just due to the differences in drug supply. But I do feel like it's a good question worth asking and worth looking into perhaps more in the future in the US population. IM could help prevent need for IV access in difficult stick patients. And then unfortunately, IN is typically the better known dosage form available to the public, even though the IM dosage form is technically available to the public. Typically, Narcan or intranasal naloxone is more accessible and lower cost and also needle-free. So going forward, I think it would be super interesting to see the results of a similar study with the United States population and drug supply, as well as if we would need different doses of intramuscular naloxone due to varying potencies of fentanyl that we have here. And then also just looking at that incidence of precipitated withdrawal and agitation due to the IM naloxone dose. So those are my sources. And if you have any questions or discussion, I would love to open it up.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.